This conference will now be recorded. This conference will now be recorded.
Okay, good afternoon everyone. Today we'll be discussing regarding the parasitic infestations. So first, we have to know a basic difference between what is infection and what is infestation. So first, infection. Infection means invasion of the microorganisms that cause a disease to the host. It is caused by the invasion of microorganisms such as protozoans, fungi, bacteria, and viruses. So the infections means it is caused by protozoans, fungi, bacteria, and viruses. These microorganisms enter the tissue of the host and they multiply, arresting the normal physiology of the cells of the host during the infection. So coming to infestation. Infestation means invasion of the insects and worms that causes a disease to the host. Okay. Here in infestation, there will be invasion of the complex organisms such as insects and worms. So you have to remember the basic difference. In infection, there will be protozoans, fungi, bacteria, and virus. Protozoans also comes under infection. Okay. All the insects and worms comes under the infestation. Here, insects or worms reproduce on the surface of the host or inside the lumen. So let's see some common infections and infestations which we encounter. First is very common amoebiasis, Entamoeba histolytica. Most commonly we can see in Indian subcontinent, Africa and parts of Central and South America. Majority of the cases will be asymptomatic. And the route of transmission is fecal-oral route. Due to substandard hygiene and sanitation and poorer socio-economic strata. We have already seen the majority of the cases are asymptomatic. So if the patient comes with a symptom, the most common is the dysentery. So first we have to see what is the life cycle. So first, the cyst. This is transmitted by the fecal-oral route. If the contaminated feces with this cyst is mixed with the water and if we ingest this water, then this mature cyst, it goes into the small bowel where there will be excision will be done there, and after this excision trophozoite is formed. Okay, this trophozoite will remain like this as a trophozoites or forms again the cyst. Okay, and this again comes out through the feces. Here this amoeba causes both intestinal and extra-intestinal symptoms. Okay, intestine symptoms, it comes into the ileum where the excision occurs. In the ileum, later it travels to the larger bowel, and in the large bowel, so you can see here, no, in the large bowel, mostly in the cecum and sigmoid area, this travels to the mucosa. It causes the ulcers. In the cecum, it causes the amoeba. In the left-sided colon, it causes the flask-shaped ulcers. Due to this, only dysentery occurs. And from here, it enters the circulation, that is the venous circulation. Through the venous, the portal vein, it travels to the liver. So this is the cause for the liver amoebiasis also, hepatic amoebiasis abscess, amoebic abscess in the liver. Okay. Other extraintestinal are, apart from the liver, it travels to the pulmonary, travels to the brain. So you can see here three routes. Non-invasive, it can come out through the feces, or it can cause some intestinal diseases like in cecum amoeboma. In the left side, it can cause some flask-shaped ulcers. And one more is the extra-intestinal, liver, lung, and brain. So the same here. The trophozoites passes in the stool, Pre-cyst will be formed. Later the cyst, there will be tough hyaline cyst wall. So this semi-formed stool contains pre-cyst cyst. It can infect the humans. It reaches in the small intestine where the excitation occurs. After this excitation, trophozoites come. So dysentery. Any patient with dysentery have to differentiate whether it is bacillary dysentery caused by Shigella or a weak dysentery. So what are the common differences? Some main differences. In bacillary dysentery, acute onset will be present, whereas in amoebic there will be gradual onset. The condition, general condition will be poor in bacillary dysentery, whereas in amoebic it will be normal. High grade fever will be present in bacillary dysentery, whereas low grade fever will be present in amoebic. Tenesmus will be severe in bacillary dysentery, whereas in amoebic dysentery, moderate tenesmus will be present. Dehydration will be frequent here in bacillary dysentery, whereas there will be little dehydration in amoebic dysentery. Feces, there will be no trophozoites, but whereas in amoebic dysentery, trophozoites will be present. Coming to the culture of the stool culture, there will be positive for organisms, microorganisms, that is bacteria and bacillary dysentery, whereas it will be negative culture in amoebic dysentery. So, how is this amoebiasis important to us in surgery? Due to some conditions caused by the amoebiasis. Okay, this first is most common is amoebic liver abscess. It needs some surgical intervention. So, amoebic liver abscess is the most common extraintestinal manifestation. You can see this in alcoholics and immunocompromised patients, and because these are more susceptible to infection. So common sites being paracecal and liver. I've already previously told you know how this goes to the liver. Again, we'll see once again the pathogenesis. First, we'll ingest the cyst. Excitation occurs in the small intestine in the ileum. Production of 8 trophozoites. Multiplication and colonization in the large intestine. Either it can go to tissue invasion and destruction. Due to this, flask-shaped ulcers are formed, mostly in the cecum, sigmoid, and transverse colon. Encystation and exit from the host in the stool. Either it can go through the stool or from here mucosa, it travels into the bloodstream, that is the portal circulation, from the portal circulation to the liver. Liver also, right side abscess is most common than the left side. So here in the liver, where are these trophocytes present? Trophocytes are filtered and trapped in the interlobular veins of the liver. Multiply in the portal triads causing focal infarction of hepatocytes and liquefactive necrosis. So 80% is involved in the right lobe because of the vein course. That is, the superior mesenteric vein runs on a striatal course through the portal vein into the larger lobe. That is a right lobe. So most common is right lobe. Left lobe is 10%. If left lobe is involved, then there is more chances of this abscess rupture into the pericardium. Okay, and it can also cause pericardial effusion, pericardial abscess, and heart failure. Multiple will be presenting 10%. Abscesses are most common high in the diaphragmatic surface of the right lobe. So this abscess cavity is filled with the fluid, that is chocolate colored fluid. This is a sterile unless and until infected secondarily. Okay, this is a chocolate colored, odorless, anchovy sauce like fluid, necrotic liver tissue and blood. Secondary infection of the abscess causes the pus to smell. So abscess is sterile unless secondarily infected. So what are the clinical features with what a patient presents with amoebic liver abscess? Usually adult young male is present common presentation. History of insidious onset of non-specific symptoms like abdominal pain, anorexia, fever, night sweats, malaise, cough, and weight loss. More specific symptoms, there will be pain in the right upper abdomen, right shoulder tip pain, referred pain can be present, hiccups, non-productive cough. Past history usually is related with recent bloody diarrhea. So, on examination, toxic anemia, upper abdominal rigidity, tender hepatomegaly, tender and bulging intercostal spaces overlying skin edema, pleural effusion and basal pneumonitis, jaundice, ascites. So, this abscess can also get ruptured. If rupture of an abscess occurs into the peritoneal cavity or pleural or pericardial cavity, this can occur. If it occurs in the peritoneal cavity, then it's an acute abdominal. We have to go for exploratory laparotomy and we have to clear the abscess and we have to put a drain and come out. So amoeboma. Long-standing amoebic infection treated intermittently with drugs without completion of a full course. It's a chronic granuloma. Most common site is cecum. Generalized ill health will be present. Patient can have pyrexia. There will be mass in the right iliac fossa. So right iliac fossa mass, differential diagnosis, you have to remember amoeboma also. Bloodstained mucoid diarrhea will be present in amoebiasis, in amoeboma. But whereas in carcinoma, there will be altered bowel habit is not a feature of right-sided colonic carcinoma. So if you find some bloodstained mucoid diarrhea with a mass per abdomen, mass in the right iliac fossa, then you can have this amoeboma as a diagnosis. Anemia can be present in both conditions due to chronic malnutrition. Coming to investigations, anemia, leukocytosis, raised inflammatory markers like ESR, C-reactive protein, hypoalbuminemia, deranged LFTs will be present. Serological tests should be done, more specific antibodies in the serum, complement fixation test, indirect heme agglutination test, indirect immunofluorescence, enzyme-linked immunosorbent assay should be done. In indirect heme agglutination, detect acute infection in non-endemic areas. Counter immunoelectrophoresis, detect acute infection in endemic areas. Flexible sigmoidoscopy can be done. Most amoebic ulcers occur in the rectosigmoid junction. There will be skip lesions and flask-shaped or collar strut undermined ulcers. Biopsy or scrapings, microscopic examination, there will be tropozoites. In ultrasound, you can find hypoechoic or anechoic lesion with ill-defined borders for amoebic liver abscess. Internal echoes will be present, necrotic material or debris will be present. Used for aspiration, ultrasound guided aspiration can be done. It can be both diagnostic and therapeutic. Diagnostic aspiration has limited value and you can send it is orderless and you can send it for further examination and color of the aspirate can be seen in under diagnostic aspiration. Later after diagnostic aspiration, therapeutic aspiration is done. Then you can also put a pigtail catheter. Large amoebic liver abscess with necrotic tissue, debris will be present. This is a CT showing an amoebic abscess. Here. This is the extension also. So coming to the treatment. First we have to go for medical treatment. If only emergency, surgical emergency is there like rupture of abscess, etc., then we have to go for surgical treatment. So medical treatment. Metronidazole is given 400 to 800 milligrams TID for 7 to 10 days and tinidazole 2 gram per day per oral for 3 to 5 days. They usually give metronidazole as it is a sterile, no need to give any other antibiotic. But if you suspect some secondary infection, then you have to add some antibiotic along with metronidazole. Next is diloxanide furoate 20 milligram per kg per day in 3 divided doses for 10 days. This destroys any intestinal amoeba, not effective against hepatic infestation. For larger abscesses, repeated aspiration is combined with drug treatment. So just a clinical classification of anti-amoebic drugs. Luminal amebicides, systemic and both. First we'll see mixed. Mixed is both systemic and luminal. You have to give metronidazole and tinidazole. If you suspect luminal amebicides, then you have to give idoquinol, paramomycin, diloxanide furoate. Systemic amebicides are chloroquine, emetine, dihydro. These systemic amebicides are useful for treating liver abscess and intestinal wall infections caused by amoebas. Coming to surgical treatment, reserved for complications such as rupture into the pleural, peritoneal or pericardial cavities. Acute toxic megacolon and severe hemorrhage are intestinal complications that are treated with intensive supportive therapy followed by resection and exteriorization. Subtotal colectomy with terminal ileostomy and closure of the rectal stump is done, but this is a rare condition. Next is Ascariasis roundworm. It is the commonest intestinal nematode. Parasite causes pulmonary symptoms as a larva and intestinal symptoms as an adult worm. So coming to the life cycle. So here the important is, their importance is trophocyte. Here is the larva. Infective larva, ingestion with food, reaches the duodenum, it penetrates its wall and go to the blood. So through the blood it goes to the lungs, from where they are coughed up or swallowed again, Loeffler syndrome. Later, finally, development will be in the small bowel. The eggs will be laid in the soil, unfertilized egg, and next fertilized egg. From the fertilized egg, infected larva comes again. Same. See, larva. Unfertilized in the feces. Unfertilized, fertilized. Unfertilized will not undergo any development. This fertilized goes to this fertilized egg forms again the larva. Okay, this embryonated egg with L3 larva. This is ingested by the oral cavity. From there it reaches the from there it reaches the small bowel. From there it reaches into the circulation and migrate to the lungs. Coming to clinical features, larval stage in the lungs causes pulmonary symptoms, Loeffler syndrome, dry cough, chest pain, dyspnea, fever. Adult worm can grow up to 45 centimeters. Its presence in the small intestine causes malnutrition, failure to thrive, particularly in children, and abdominal pain. It also causes small intestinal infection, and even the patient comes with a perforation also. So bolus of adult worms incarcerated in the terminal ileum is a surgical emergency. Rarely perforation also occurs in the small bowel due to ischemic pressure necrosis from the bolus of worms on the wall of the bowel. So these worms can even migrate to the CBD, causing obstructive jaundice and ascending cholangitis. And if this worm obstructs the pancreatic duct, it causes acute pancreatitis. So investigations, there will be increased eosinophil count here. Stool examination shows ova. Sputum or bronchoscopic washings may show charcot-laden crystals or the larva. This is a chest radiograph showing the fluffy exudates in the Loeffler syndrome. This is the barium meal and follow through bolus of the worms in the ileum or lying freely within the small bowel. So you can see the round worm. Okay. This is the barium meal follow through. Ultrasound may show a worm in the CBD or pancreatic duct. MRCP, an adult worm may be seen in the CBD in a patient presenting with features of obstructive jaundice. Plain abdominal radiograph and contrast CT scan will show the worms as tubular or curvilinear structures. I don't know if you can appreciate or not. See, this is the round worm in the CBD. This is the portal vein in the cystic duct. And here, this is the round worm. This is the MRCP. This is the ultrasound. So coming to the treatment, the pulmonary phase of the disease, self-limiting, requires symptomatic treatment. Intestinal disease, you can give anti-helminthic drug. So when is the surgery done? Surgery is reserved for complications, intestinal obstruction. At laparotomy, if you find the bolus of worms in the terminal ileum, then you have to milk the worms to the IC wall into the colon for natural passage in the stool. Postoperatively, hypertonic saline enemas may help in the extrusion of the worms. So if you find some bolus of worms in the intraoperative surgery in laparotomy, do not open there for removing the worms outside. You have to milk into the IC valve into the cecum. So strictures, gangrenous areas or perforations need resection and anastomosis. If you find a perforation, if the bowel wall is healthy, enterotomy and removal of the worms may be performed. Okay. Next, if you find anywhere perforation, you have to bring that bowel outside and there only you have to do ostomy. Rarely when perforation, the parasites may be found lying free in the peritoneal cavity. It is safer to bring out the site of perforation as an ileostomy because in the presence of large number of worms, the closure of an anastomosis may be at risk of breakdown from the activity of the worms. So for risk of again leakage, you have to do ostomy there. So CVD or pancreatic duct obstruction, how do you treat? You can do endoscopic removal or you can go for laparoscopic or open exploration of the common bile duct. Cholecystectomy is also carried out. A full course of anti-parasitic treatment must follow any surgical intervention. Coming to a type of liver fluke, that is Oriental cholangiohepatitis or Asian cholangiohepatitis caused by Clonorchis sinensis. It is a liver fluke. Resides in snails and fish that acts as an intermediate host. So ingestion of this infected fish and snails eaten raw or improperly cooked causes the infection in humans and other fish eating mammals, which are definitive hosts. Pathology is parasite matures into the adult worm in the intrahepatic biliary radicals. Intrahepatic bile ducts will be dilated, there will be epithelial hyperplasia, periductal fibrosis will be present, dysplasia causing cholangiocarcinoma. The eggs are dead worms. These forms a nidus for the stone formation in the gallbladder or CBD. Intrahepatic bile duct stones are also caused by the parasite producing mucin-rich bile. The dilated intrahepatic bile ducts may lead to cholangitis, liver abscess, and hepatitis. So clinical features are disease may remain dormant for many years. Non-specific clinical features like fever, malaise, anorexia, upper abdominal discomfort, fever with rigors due to ascending cholangitis, obstructive jaundice, biliary colic, and pruritus from stones in the CBD. Obstruction of the pancreatic duct by an adult worm causes acute pancreatitis. Advanced cases, there will be abnormal LFTs. Examination of stool or duodenal aspirate may show the eggs or adult worms. Ultrasound scan of the hepatobiliary system and ERCP are also diagnostic. So coming to the USG findings, uniform dilatation of small peripheral intrahepatic bile ducts with only minimal dilation of the common hepatic and common bile ducts. Worms or eggs represented by thickened duct walls with increased echogenicity, non-shadowing echogenic foci in the bile ducts. So coming to the treatment, drug of choice is praziquantel, 25 milligrams per kg per oral TID for 1 day, and albendazole 400 milligrams per oral once a day. That is TAT dose only once. Surgical treatment is cholecystectomy, exploration of the CBD, and some form of biliary enteric bypass like choledochoduodenostomy or choledochojejunectomy will be done. Okay, next is filariasis, caused by Eukarya bancrofti. Variants of the parasite are called Brugia malayer and Brugia timori in 10% cases. Most common in India, China, and Indonesia. Filariasis is the most common cause of long-term disability after leprosy. So, first, L3 larva. Okay, this L3 larva will be residing in the mosquito probiosis. From this mosquito takes a blood meal, it ingests into the human skin. Later, through these adults form in the lymphatics. These adults produce sheeted microfilaria that migrate into lymph and blood channels. Okay. This is nocturnal. So this comes again beneath our skin at a time of 2 a.m. or 4 a.m. where the mosquito again takes a blood meal, ingests the microfilaria, and this microfilaria shed sheets penetrate mosquito's midgut and migrate to thoracic muscles. There L1 larva is formed, again L3 larva is formed from L1, and this reaches the migrate to the head and mosquito's probiosis. From there again it will come to the human. This is the cycle. So there will be acute presentation, episodic attacks of fever with lymphadenitis and lymphangitis. Adult worms cause lymphatic obstruction. Massive lower lymphedema will be present. Obstruction to the cutaneous lymphatics causes the skin thickening. You can see all this in the lymphedema class. Secondary streptococcal infection can also occurs. So, recurrent attacks of lymphangitis causes the fibrosis of the lymphatic channel. Due to this, the lymph will be grossly swollen with thickened skin, leading to elephantiasis. Bilateral lower limb filariasis is associated with scrotal and penile elephantiasis. Early on, there may be a hydrocele underlying the scrotal filariasis. This is the elephantiasis and this is the filariasis of the scrotum and pins. So, chyluria and chylous ascites can be present. Respiratory tract causes dry cough due to tropical pulmonary eosinophilia. Nocturnal peripheral bed smear is important because I have already previously told you, these microfilaria are nocturnal. So, nocturnal peripheral bed smear can see immature forms of microfilaria. Parasite may also be seen in chylous urine, ascites, and hydrocele fluid. Treatment is DEC 100 milligrams TID for 21 days. Early stages of limb swelling, you can give intermittent pneumatic compression. Later, surgeries will be present. But these surgical procedures are largely unproven and hence they are rarely performed. Okay. That's all for today's class. Thank you.